HIVStory, the beginning of the end of HIV. My name is Sean Cranberry, and I'm your host tonight. I'm also one of the volunteers who helped found Evening Rounds way back when we were the local chapter for the Healthcare Social Media Canada, HCSMCA group back in 2010, I think is how far back that goes. So now some housekeeping things. You can follow us on Twitter at Evening Rounds. The hashtag is #eRounds. We're on Facebook and YouTube as well as the social media creep continues. We have the Wi-Fi as mentioned. We are videotaping this session and we'll be posting it on our website along with photos from tonight. So look good. We would like to especially thank our friends and presenting partners, Providence Health Care, who have invited us to use this conference center. It's a really nice room. And we'd like to welcome Arthur Lee, Communications Specialist at Providence, to say a few words at this time. Very prompt. Arthur Lee, thank you.
Thanks, John. Hi, everyone. Thanks again for being here. My name's Arthur Yee. I'm a communications specialist with Providence Health Care. And on behalf of Providence, we'd like to welcome you to Evening Rounds Volume 5. Thanks to everyone joining us in person and on Twitter, #eRounds. We're very proud to be a co-sponsor for this series and partner. And again, a big thank you to Signals for making this happen. I know that our presenters have a great talk lined up for us tonight, so I don't want to take up any of their time. So without any further ado, I'll turn it back to you.
Thanks.
Thank you.
One thing I forgot is that this microphone works. And it also is connected to the video. So my previous remarks, it probably just looks like I'm gesticulating wildly and no one will be able to hear me. So yeah, presenters, remember that that's what this is for. Uh-oh. Let me turn off my computer. And if, for all of you, if you're interested or if you're the organization you represent or the team that you're a part of would like to share some ideas or would like to get more involved, you can chat with one of us after, or you can connect with us via any of the social media internet channels. And the next Evening Rounds is Volume 6 on March 19th in this room. We're just finalizing the details on the presentation and we'll announce the topic via social media and our newsletter very soon. So without further ado, let's get to it with our friends. I'm going to give a brief introduction to each of them, and then they're going to present one after another. So just as an introduction, Afshan Nathoo, did I pronounce that relatively correctly, is a clinical lead for the Acute Care Routine HIV testing strategy with Providence Health Care and Vancouver Coastal Health, an adjunct professor at the UBC School of Nursing. Meaghan Thumath, Close enough, is a registered nurse and has been involved with the HIV and AIDS work since 1994 with expertise in gender, harm reduction, and public health. As a vice president of FCV, Simon Hardy is responsible for developing FCV's creative product for clients, leading and inspiring teams to arrive at creative solutions that engage customers and deliver results. And Vic Kambli, Senior Director of Strategy, is responsible for taking FCV's teams to develop and evolve a range of solutions that apply insights and enable organizations to achieve a variety of goals. And please, take it away.
Good evening, and thank you all for being here. So I'm going to start off with a brief rationale, the public health rationale around routine HIV testing within the Stop HIV/AIDS project. And before I begin around the rationale, I'm going to go through a few stats. So currently, whoops, I'm going to skip that slide. Currently, 30 million people have died from AIDS-related illnesses across the world, and over 60 million people have been infected with HIV to date since the epidemic started in the 80s. Approximately 21,000 Canadians have died from AIDS-related causes, and currently 4,500 people in BC are living with HIV but are unaware of their HIV diagnosis. On average, one person is diagnosed with HIV in BC every single day, and approximately 3,100 Vancouverites have died of AIDS-related causes. So what does this mean and what has really changed in HIV? Well, most importantly, HIV treatment has significantly advanced. And so essentially what this means is treating an HIV-positive individual reduces their viral load, which is the amount of virus circulating in their blood, which is able to render them approximately 96% less infectious to their partners. So not only is HIV treatment having a significant impact on the quality of life of individuals, but it's significantly reducing the risk of transmission in the population. So the data shows that the majority of HIV transmission are from people who are unaware of their infection. So if we focus on the two white bubbles, what we see is that 46% of new infections are transmitted by 79% of individuals who are aware of their infection. Yet the larger majority of 54% of new infections are transmitted by only the 21% of individuals who are unaware of their infection. So historically, what we have done as the healthcare system is really focused our strategies on the 79% of those individuals who we are aware of HIV infection. And we haven't really focused or encompassed our strategies around the 21% of individuals who are living with HIV but who are unaware of their HIV status. So the Stop HIV/AIDS project really expanded HIV testing and treatment to encompass the broader population living with HIV. So this graph really describes the impact of HIV treatment known as HAART, highly active antiretroviral therapy, on new HIV transmission, or on new HIV diagnoses. So the blue line describes individuals on HIV treatment, and the red line describes new HIV infections. So between 1996 and 2009, what we see is that the number of individuals on HIV treatment substantially increases from about 1,000 to above 5,500. At the same time, the number of new infections substantially decreases. So what does this really show? This shows that the concept of treatment as prevention really works, where treating an HIV-positive individual not only reduces or increases that quality of life of that individual, but has a significant impact on the population health of our community. So in the end, what does this all mean? Diagnosing and treating infected individuals earlier can reduce the community viral load, so the overall viral load in our population, and can then have the potential to change the epidemic. And when we talk about changing the epidemic, we talk about reducing the number of new infections we see every year. So to date, we see about 150 to 200 new infections in Vancouver, and the goal is to substantially reduce the number of new infections we see over time. I'm now going to pass it on to my colleague Meaghan to discuss the testing strategy in detail.
Great, thank you, Afshan. Welcome, everybody. So again, I'm Meaghan Thumath, and I was charged with leading a strategy around HIV testing, primarily in community settings. And so I thought we'd just review, before we get into the communication strategy and the support that we got from our colleagues at FCV, kind of the what did we do? To give you a bit of history, initially our efforts primarily focused on the top of this triangle. So here you see risk-based testing, in the middle you see routine testing in sort of high prevalence settings, and routine testing in general healthcare settings. I'll talk about what those words mean, but kind of the history is that we were primarily focused on risk-based testing. So that's sort of like demanding that patients identify that they're at risk, and then they present to a clinic to say, hey, I think I need an HIV test. And we also told family doctors and clinicians, hey, you need to test men who have sex with men, people who use injection drugs, and sex workers, and don't really worry about everybody else. They're not at risk. And that was the message that kind of got through really healthcare providers as well as patients, and everyone sort of internalized that message. I don't need to worry about HIV unless I'm part of one of those risk groups. And to me, it really hammered home when I was working in the downtown east side on one of our pilot projects as a nurse, in the last summer, a peer HIV testing project, and I diagnosed a woman, gave her diagnosis, and she was kind of in her 60s, and she actually had been a sex worker, had been an injection drug user, and was a First Nations woman herself, and she was shocked that she had HIV, and she said to me, but I'm not injecting anymore, and I'm not working in sex work anymore. How is this possible? And it was amazing to me that from a clinician point of view, she met all of my risk categories, but even herself had internalized this sort of like, oh, I'm not one of them. And that's where we started to learn, like, maybe the message we've been giving about risk-based testing is actually stigmatizing even to these communities, to First Nations people, to the gay community, but it's also stigmatizing to clinicians who are just sort of automatically making assumptions, oh, I don't need to offer a test to this person, they're not one of them. So it felt like a bit of an othering strategy. At the same time, it's still a central component of Stop HIV/AIDS testing strategies because we know it works. So we know it works to provide outreach to gay men in bathhouses, and we've scaled that up in the project. We know it works to improve what we call contact tracing, where you interview someone who's diagnosed with HIV and you go on and ask them about their partners and offer those partners a test. Those strategies are critical to the HIV testing response that we have in Vancouver Coastal. We want to preserve them and scale them up. But we also added really 2 new layers to our approach, and that's the sort of 2 second levels of the triangle that we really weren't doing previously. And that's offering a routine test to everyone who presents to any of our community-based settings. So that's things like our detox, our drug court, our primary care centers that serve a lot of gay men, such as Spectrum or Three Bridges in Vancouver. It's really saying, hey, we want to offer you a routine test, no judgment. We don't want to interrogate you about who you've had sex with and who you've shared drugs with. We just want to say everyone should have an HIV test who comes here. And then the third strategy was expanding it even broader to say we want to offer a test to everyone who presents at a healthcare setting. And that includes hospitals and it includes family practice. And so that strategy, and Afshan will explain because she really led particularly the acute care, and my colleague Kendra's in the back who really led the GP or family doctor strategy. And that's a newer one that we're working with. But again, more patients see a family doctor really than come to any of our other direct services. So we wanted to reach out to family doctors in the community and say, hey, we want you to offer an HIV test really to all of your patients who present for care. And in that way, our goal is to really improve early detection of HIV, because we know the earlier you know your diagnosis, the longer you'll live. And we also know that that has a preventative impact that Afshan outlined. So if you know your diagnosis and you're engaged in care, you're getting antiretroviral therapy, you also can't transmit the virus. So really broadening our strategy. And some of the scope that the project that I particularly worked with was primarily settings like those detoxes, and then others again led the family practice initiative. We also really worked hard at improving our rapid HIV testing pilots. So that included peer HIV testing in the inner city. It included introducing rapid HIV testing in our bathhouses and public sex venues where gay men are. Strategies with youth, including a partnership with Youth Co called No on the Go. We're doing mobile testing in a van in public sex venues like Rec Beach or Stanley Park, but also bars and clubs. So just kind of expanding access to testing where patients are and where it's convenient for them. And then another strategy we did, again, around HIV testing in existing sites involved working very closely with, for instance, the abortion clinic. I might use that as an example. We met with their staff and they said, oh, we don't do HIV testing here. Just hasn't come up, didn't think we were allowed to do it. So we said, well, every person who comes to an abortion clinic has really, by virtue of using the service, actually having unprotected sex. So we thought that was a setting where we might have a higher prevalence of HIV. We gave the staff education on HIV basics. We met with their leadership, got sort of buy-in from them, and then we worked with the clinicians to say what would be the right time to offer this, and found out, when do the women have time to think about if this is the right space to do an HIV test. And we found their abortion readiness counselor was actually probably the best person to offer that. And so it was about routinely offering an HIV test and how do we get the results and all of that. So our team worked with them. And then we provided the companion tools, which really came from our partners at FCV, and that was the social marketing campaign that they'll get into. But it was critical to have a kind of campaign that also was clinician-facing, so we called it our healthcare provider influencer campaign, as well as public-facing, so that when women presented to that abortion clinic, they weren't like, what are you talking about? Why are you offering me an HIV test? They kind of had already hopefully heard the message of it's different now and Change HIVStory, so that it wasn't coming out of nowhere. And I'll let these guys talk a bit more detail about that. We also found it was really important to meet with the clinicians and say, what are your goals? How many of your clients do you think you'd like to screen for HIV? And they might choose 50%, they might choose 90%. But the point was it was their goal, they selected it. And then they had their baseline data to say, this is how many clients we have, this is how many we were testing before you started. Often, for instance, with abortion, it was none. Some sites it might have been, we were testing 5 or 10% of our clients. And they said, we want to now test 50%. And then every month we got back to them with a report. This is how many clients you've tested. You're meeting your goals, or you're exceeding your goals, or you're not meeting them. We need to change the strategy. And then we would often come to our social marketing expert partners for advice. So they're not meeting their goal. What do we need? We need different posters, or we need things like this. These lanyards, I almost took this off, but I thought, oh, this is kind of a good example. It says, share the word, take the test. This is something that all the clinicians would wear to sort of be public-facing. Oh, no, I'm offering this to everybody. I've got a poster that says, I'm offering a routine HIV test. It was a really concrete way so that people felt safe in accepting the test. So that was a critical partnership. The routine screening in acute care settings that Afshan and Kendra co-led was about opportunistically testing all adults in acute and primary care, along with our medical health officer, Dr. Reka Gustafson, who was a huge leadership in this initiative, as well as community. And we wanted to say everyone who presents who hasn't had a test in the last year should have a test. Not to say we don't still have outreach, targeted testing with the other communities I talked about, but really this is to get those folks who don't consider themselves at risk. And in acute care, it was huge. A lot of stigma reduction happened, which I thought was really exciting partnership with our social marketing folks, because even the clinicians still had such crazy misunderstandings about HIV. And so it's been really rewarding to have social marketing and operations kind of working together. With that, I'll pass it over to my colleagues.
Thanks, Meaghan, and good evening. I'm going to talk about the insights that led us to the Change HIVStory campaign and the communication construct that led to the campaign strategy itself. What I'm going to start with is this great Victor Hugo quote, where he states that nothing is as powerful as an idea as whose time has come. And although at the time the great poet was talking about the French Revolution, which was the big social movement of his time, this is actually a maxim and a construct that's held true throughout history. Whether you look at any of the 4 examples of big social change that I'm showing right now, or any other large social movements as a whole, they've really happened, and the key impetus to them has happened when people have come together around a shared ideal, and over time created the social momentum necessary to influence political structures and existing perceptions to change to really deliver that change that they're going towards. Through working with VCH and Providence Health Care, it became clear to us that similar opportunities existed around the HIV and AIDS issue. So this begs the question, if this is so glaringly clear, what are the big barriers to actually achieving this kind of social movement around the HIV and AIDS issue? Well, the more and more we spoke with the team, the more and more we realized, and Meaghan and Afshan have touched on this a little bit already, that the big barrier to actually connecting and the big barrier to actually turning this into a social movement issue is the disconnect between reality and perception and what actually exists out there. Meaghan and Afshan already touched on a few of the points, but at the end of the day, there were really 3 big disconnects that we leveraged as insights in the building blocks of the communication strategy for this campaign. The first of these was existing attitudes and behaviors about HIV and AIDS. So when HIV and AIDS first stormed onto the public conscious in the 1980s, there was a lot of sensational and sometimes ill-informed media coverage about what the disease and the issue actually was about. As a result of that, that swarm of media coverage is stuck in the mindsets of a lot of individuals out in the community, and frankly, images like those out of Philadelphia are the first ones that come to mind when people think about the issue. In fact, in some more extreme cases, some people out there still believe that a positive HIV diagnosis equates to a death sentence. So really talking about the disconnect that exists between the perception and the reality of the issue itself. The second insight was just a lack of knowledge amongst the general public, and it similarly touches on what I was speaking about the lack of knowledge On a similar note, there's a general lack of knowledge among the public through modern treatment methods, people with a positive HIV diagnosis can live a relatively normal life. So once again, the disconnect between perception and reality on the issue itself. And finally, and I think Meaghan talked about this really well, there's that "it can't happen to me" phenomenon and mindset. The thinking that HIV is concentrated to a few high-risk communities, and testing programs are in place to stop the epidemic in those communities only. So it was armed with these insights that we worked with the team to develop a communication strategy that helped close the gap between perception and reality, which was ultimately our goal, to help push more testing itself. Like any communication strategy, we had to come forward with a clear goal of what it was we were hoping to achieve. So our goal was to raise awareness to increase the number of HIV testing in the Vancouver area. The awareness component to this was key because it complemented the efforts that Afshan, Meaghan, and their wonderfully talented teams were already doing in clinic and complementing that effort as a whole. How do we do this? Well, 2 key points. The first one was to remove the stigma around HIV testing, and the second was to encourage people to take an HIV test as a part of their regular healthcare routine. So that's all well said and good, and it sounds great on paper, but when it actually comes down to it, we've got to talk about how you actually do this. How do you take an issue that's potentially very, very volatile and very, very sensitive and turn it into a cry for a social movement as a whole? What we looked at in terms of structuring the comm strategy was into the science of human motivation. The guy who you see up on the screen right now is Simon Sinek, and despite his somewhat scruffy appearance right there, he's one of the most foremost minds on human motivation and foremost cultural anthropologists in the world right now. He's developed this construct called the Golden Circle, which actually articulates very clearly at an archetypal level why certain leaders, businesses, organizations, and ideas resonate with people and inspire action, and others don't. And then rather have me going through it in detail, I'll let Mr. Sinek talk about it himself.
Why, how, what? This little idea explains why some organizations and some leaders are able to inspire where others aren't. Let me define the terms really quickly. Every single person, every single organization on the planet knows what they do, 100%. Some know how they do it, whether you call it your differentiating value proposition or your proprietary process or your USP. But very, very few people or organizations know why they do what they do. And by why, I don't mean to make a profit. That's a result. It's always a result. By why, I mean what's your purpose? What's your cause? What's your belief? Why does your organization exist? Why do you get out of bed in the morning? And why should anyone care? Well, as a result, the way we think, the way we act, the way we communicate is from the outside in. It's obvious. We go from the clearest thing to the fuzziest thing. But the inspired leaders and the inspired organizations, regardless of their size, regardless of their industry, all think, act, and communicate from the inside out. Let me give you an example. I use Apple because they're easy to understand and everybody gets it. If Apple were like everyone else, a marketing message from them might sound like this. We make great computers. They're beautifully designed, simple to use, and user-friendly. Want to buy one? Meh. And that's how most of us communicate. That's how most marketing is done, that's how most sales is done, and that's how most of us communicate interpersonally. We say what we do, we say how we're different or how we better, and we expect some sort of behavior, a purchase, a vote, something like that. Here's our new law firm. We have the best lawyers with the biggest clients. We have, we always perform for our clients, do business with us. Here's our new car. It gets great gas mileage. It has, leather seats. Buy our car. But it's uninspiring. Here's how Apple actually communicates. Everything we do, we believe in challenging the status quo. We believe in thinking differently. The way we challenge the status quo is by making our products beautifully designed, simple to use, and user-friendly. We just happen to make great computers. Want to buy one?
So that's actually part of a larger TED Talk that he gives, and if that piques your interest, I highly recommend you take a look at it on YouTube. He actually gets into the physiological nature of why that construct works and why it resonates with people. But essentially, that was the core of how we went about structuring the communications for the Change HIVStory campaign, is we started with the why, evolved it into the how, and then started talking about the what, and hoping to get, and the idea was to get buy-in from people as we started going through that construct. So what was the why for the Change HIVStory campaign? The why was that we have a unique opportunity. We believe we have a unique opportunity to be a part of history. We can come together as a society to end HIV. The how? Well, you empower yourself with information about HIV, and you spread the word that HIV is in fact different now. And the what was to take a test and join the movement. So with that being said, that was essentially the communications construct that we used to develop the Change HIVStory campaign. I'm going to ask my colleague Simon Hardy to come up stage now and actually talk through the details of the campaign itself. Thank you.
Good evening. Thanks, Vic. So the campaign. Well, I just firstly wanted to start with a short history of Change HIVStory, which began as It's Different Now. And Change HIVStory is actually the second part of a campaign that began back in, I guess, November 2011, with a website that FCV worked with VCH in Providence to kind of really start by presenting the facts about HIV in Vancouver and start to kind of help educate people about the work that was being done here and what they could do to sort of be a part of it. So we began with this very simple website and also a bunch of transit shelter posters which were featured all over the city. You may well remember them running last winter. So that kind of got a lot of people's attention on the issue and kind of brought a lot of people to the website. So we generated quite a lot of traffic out of that. But last summer, what we really had to do was go back, as Vic said, to really look at how we could move this forward, because the facts on their own are just not enough to kind of engage people and make them come forwards to get tested and get involved. So we really need to find a way of engaging with this kind of broader audience that think that HIV couldn't possibly affect them at all, and kind of find a way to speak to them. So really, the way to do that is not to just present the facts. The way to engage people is really to get them to kind of come together and work together to try and solve this problem. So what we did was we did literally sort of take a look at the past, and we're going to show you a video we made first. I'll take you through kind of the campaign stage by stage. But the first piece we did was a video which we presented and launched last summer, which really kind of looked at some of the biggest kind of social movements of the last 100 years and drew a parallel of those with kind of how important an issue HIV is now, and how much kind of it affects every one of us in the same way that civil rights did, in the same way that apartheid did, in the same way that gay rights did. So I'll show you the video and then I'll take you through the rest of the campaign.
How do you change history? You can change history by walking and marching. You can change history by speaking and teaching. You can change history by taking a stand or taking a seat. But the best way to change history is when you becomes we. We tore down that wall. We marched for equality. We made sure that love knew no boundaries. Now you can become we right here in Vancouver. We can end HIV. We can change history. Sounds impossible? It's actually really simple. It's all about telling everyone that HIV is different now. You probably still think that HIV is a terminal illness, but it's not. If you catch the disease early on and start taking the prescribed medication, you can live a near normal life. The advances in treatment now allow an HIV-positive partner to live a full life with a partner who is negative. In fact, a person living with HIV on treatment could be up to 96% less likely to transmit the disease to a sexual partner. In some cases, that medication can be as little as 1 pill a day. And if we can stop the transmission, we can stop the disease. It begins with a test. Testing today can range from a blood test that'll inform you in about a week to some locations where a prick of the finger gets you a result in 60 seconds. Diagnosing HIV early changes everything. It prevents the virus from attacking your body, and it prevents it from spreading through our communities. All each of us has to do is step up and take a test. Changing history is that simple. Testing centers are available throughout the city, or just ask your doctor at your next regular visit. And if your doctor offers a test, say yes. It's just the responsible thing to do. Then, share the word. Tell people that HIV treatment has changed. Tell people that testing has advanced. Tell people that the entire approach to HIV is different now. Let them know that by choosing to take a test, we can all end HIV. This is a fact. We are so close. Right here in Vancouver, we can be the epicenter of a movement that will change our city, that will change the world, that will change history. The beginning of the end of HIV. But to become we've got to have you. We need you to do your part. We need you to share the word, take the test, join the movement. End HIV. Change history. Learn more at itsdifferentnow.org.
So that was the video we launched with, and really the kind of job that video did was take this very large and complex and often sort of controversial issue and bring it down to a local level and then down to a personal level, so that if you lived in Vancouver, it's very hard then to kind of ignore it or walk away from it, because we've kind of shown that not only have we kind of shown you how it affects you here in Vancouver, but it's how you can then make a difference to go back out and affect the rest of the world. So we kind of had a press conference to kind of launch this, and it was more successful than we really could have ever imagined. So we first had a private presentation for media sales directors, so the people that kind of sell space on newspapers and TV, and generated over $1 million of donated media. We then had a press conference with Dr. Montana and generated like a further sort of $700,000 in earned media. And what that's kind of translated to is some of the networks are still running 30-second version of that video, and it's been on since, I guess, July last year. And the story didn't stay in Vancouver. We got international press covering it, so we got covered in Mexico, in Vietnam, in China, and across Europe. So it really kind of started to resonate with people, this message. And we're going to kind of look in a little while at just the figures and kind of what that means. But I just want to show you some of the other work as well. So share the word, take the test, join the movement. Again, just kind of follows this why, how, what structure. So the website we had, which is still live at itsdifferentnow.org, just urges you to do that. So it gets you to share the kind of, watch the video, share it on social media, and then kind of find out where ultimately you can go and take a test, as well as presenting kind of lots of the information that we had on the original site. And then we also had a bunch of print and digital executions that ran online and also in Global Mail as well. So there's 3 examples here with Martin Luther King, the gay rights message, and also the kind of women's message as well in the 60s. So lots of kind of different work, but kind of drawing on these huge social movements in the past, which kind of drew a really strong parallel with where we are now with HIV. And with that, I'll hand over to Meaghan to kind of talk about how that ended up.
Thank you. Great. So real-world results. Clearly, the results I'm going to show to you relate to all the arms of the strategy, so both the clinicians going in at the ground level and working with clinic-by-clinic sites, as well as the marketing campaign. And so we haven't found a way to tease those out, if anybody has any ideas, beyond just presenting it all as one, but I think we couldn't have done one without the other. So this just gives an example of one of the sites we implemented in, which is our Vancouver Coastal Health primary care clinic. So those, if you know, familiar with any of them, they're things like Three Bridges or Downtown Community Health Clinic, as well as some of our partner clinics like Spectrum or Mid-Main. And at those sites, we initially started with going out to clinicians and saying to them, we'd really like you to offer HIV testing routinely to all your patients. And so in the darker blue bar is 2009 and 2010, which was the early days of the STOP project, so the green and the dark blue. And that was Dr. Gustafson and I going out and giving the rationale in a really boring PowerPoint and sort of saying, yeah, do HIV testing. And everyone said, that sounds really great. Yeah, we're going to do it. And you can just see the line is pretty much flat. So we didn't have the impact we wanted to have. And this sort of dramatic shift with the red little triangle is when we actually started working with FCB, started working with sort of UBC and practice support programs to figure out what is it that actually makes clinicians change their behavior. And from our social marketing experts, we learned it's about engaging with them emotionally, it's about having tools and strategies that actually support them to make a practice change, like shifting from waiting for a patient to ask for an HIV test to, no, I'm going to routinely offer it in a simple, clear way with confidence, and I'm not going to be afraid of the why question. And I'm going to have a simple answer as to why I'm routinely offering this to you. And then I'm also going to have posters up, like Change HIVStory, that support that practice, so that when a patient says, oh, why are you targeting me? You can point to the poster and say, no, we offer this to everybody in our clinic. I'm not signaling you out. I've got the lanyard. There was pie plates, and it really helps the clinicians not be afraid, and the patients also to understand that they weren't being targeted, because essentially it boiled down to stigma. Like, HIV is still a highly stigmatized disease. So this campaign really helped us debunk that and know nothing is going to change if we keep the sort of steady state. And then, so you now see this sort of blue line where we doubled, increased by 50% our testing rates in the blue, and 2012 is the orange. And it's not just about testing rates, it's also about, did we actually succeed in diagnosing people earlier and more often? And so in the small print, you see 23 new HIV clients diagnosed, and a real increase in number of folks we were getting engaged into care. And this doesn't have our slide on advanced HIV diagnosis, but we were really decreasing the amount of people we were seeing later in their end-stage disease and meeting people earlier. So that was primary care, but we did the same thing in abortion clinics and addictions clinics, mental health clinics, many other sites. Question?
In the previous slide, there was
Sure.
a big spike at around March. Can you explain what the March
The
spike?
red, the March spike is kind of launching of It's Different Now, probably the first generation of it, not Change HIVStory, but the first It's Different Now.org, as well as just a radical change in us going into people, and rather than just talking and saying, hey, please change, I started going in and saying, hey, how many clients do you have? What's your baseline testing data? Oh, you only test 5% of your clients? They often didn't know, because we would go to them and say, you should test. And they say, oh, we already test. But it wasn't until we started saying, you've only tested 5% of your clients. So you see 2,000 and you've only done 100 tests in the last year. So you're really not testing. You think you're testing and you're not. And then going in and setting goals with them. So it was the real dramatic practice support program combined with marketing.
But maybe I'm not understanding this slide. It looks like there's a spike every March, right?
But not the dramatic doubling. So
No, I was just curious what that spike every March was related
people
to.
often test more in summer than winter. In the kind of HIV world, we call it sometimes the summer flu, because people do come before summer and after in testing.
Okay.
People are busier, they're out more. People test less around Christmas and January and those kind of trends. Sorry, I didn't understand your question. But yeah, definitely we've never seen that doubling before the project. And this is, again, represented across the entire Vancouver Coastal Health region. So it's all of the tests done in our entire city. So this represents the impact of the Acute Care Project, the Community Project, as well as the Family Practice Project and the marketing campaign. So you see our historical trend is the blue line, and then the post sort of Stop HIV/AIDS project. Again, we're at a 50% increase, which was our goal for the project, and we were accountable with the ministry, as well as a kind of increase in our diagnoses. In terms of acute care, I'm going to pass that over to Afshan, because she's the one who has done all of these labor-intensive chart audits and can speak to acute care, and then hopefully answer questions after. Thank you.
So this table really describes chart audit data, which was quite labor intensive, but we went into various units where we had implemented testing and gone into individual patient charts to collect data on whether the test was offered, whether it was accepted, if it was not accepted, why it was not accepted. And then this was really our tool to go back to the docs and say, you are testing, you're not offering, and to have that discussion with them. So this is data from 3 hospitals, St. Paul's, Mount St. Joseph, and VGH. And the offer rate is Currently, around 46% at St. Paul's, MSJ 63%, and 34% at VGH. They weren't always this high. When we launched in October 2011, St. Paul's had a relatively good start, but the other two hospitals started off quite low, and this is really where the It's Different Now campaign came in and played a role in terms of the tools and resources we were able to use to engage providers. And so, things like lanyards and books that we use to engage physicians. It seems like a simple idea, but it was our way of having a conversation. So I could go onto a unit, for example, and talk to a resident and say, would you like a book? Would you like a lanyard? Let me talk to you about HIV testing. So it was sort of that bridgeway into having that discussion with them, and also giving them something to hold on to and to remind them that this is really part of routine care. And then, of course, the posters played a crucial role. At first we printed something like 300 or 400 posters. And in acute care, I don't know if you've walked through the hospital, I don't think you can walk anywhere without seeing an HIV testing poster. We probably quadrupled the number of posters just to get the message out. And that really impacted not only public awareness, but it was more of a support system for the physicians to begin routinely offering. Like they because they saw it, they realized that this was here to stay. It was part of the institution, and that their senior leadership had endorsed it, and that they could begin engaging patients in that discussion. So those were the tools where we really used over the years and the months to increase testing. So overall today we're at about 35% of admissions get tested for HIV. We've had 19 cases. This is just within the departments of medicine. Our overall number of cases is about 38 across the 4 sites and various departments, which gives us about a yield of about 5 per thousand. So to make sense of that, that's about 5 times the cost effectiveness threshold to do routine HIV testing, and so a highly effective strategy. In regards to the cases in acute care, I think what was most shocking is that we were not only able to diagnose individuals late in the course of disease, which you would expect in an acute care setting because people come in quite sick, but we were also able to capture people in acute infection, so early on in their infection. So it was a place of increasing access to testing to those who already test in the community and to those who have never tested before. And so this graph really shows a high-level data. It's hospital-level data, and it really, I think, goes to show the impact prior to the testing strategy and after the testing strategy. So we launched in October of 2011, and in November of 2011 is when IDN launched. So you can see in 2010 we averaged about 200 to 250 tests a month, and that dramatically increased as we launched the strategy. And up till September 2012, we more than 4 times increased testing rates at the 4 hospitals. So overall, we've up until September 2012, we've done 6,291 tests, which is about 13% of all admissions in the 4 acute care hospitals. This is 4 times higher than the equivalent period in 2011. 23 admitted patients have been diagnosed, and up until that time period, so the overall percent positivity for that Vancouver acute care population is about 4%. So that's where I'm going to end, and actually we're going to end and open up for some discussion. So thank you very much for your attention, and all of us are here to answer any questions or engage in any discussions.
One housekeeping thing.
Sure.
Hi, everybody. Sorry, I didn't mention it earlier, but we do have individual microphones for every seat. So if you want to ask a question, please raise your hand, and then you just hit the button at your microphone and just hit it once, and then your question will make it through to the video. And so people who can watch this later will be able to hear what it is that you're asking and be able to make sense of the context for which these friends are speaking. So do you guys want to all come down at the same time, and then people, or do you want to answer from your seats? Maybe that's... Well, yeah, if you come down here, then the video camera will be able to see you. And again, common sense, or sense will be made for the viewers later. So please feel free, raise your hand or hit your button and ask away. Thanks. Thanks, guys.
The Mount St. Joseph number was higher. Do you guys know why?
We can only assume, but yeah, for a couple of reasons. The number of physicians that work in that hospital is much smaller, so you're able to more effectively communicate with a smaller group of physicians. There are also a group of physicians that don't transition very often. So because it's a smaller hospital, those physicians don't switch over and rotate as quickly as physicians in the wider hospitals. It's also a smaller group of residents, so you don't have as many medical students and residents rotating through that hospital. So the communication is a lot stronger and smoother, and so they were able to pick it up and communicate amongst themselves. And once 3 of them started, it was just about getting the rest of the 10 additional to start, and they all sort of took it on. They've really championed this initiative.
Thanks.
Yes.
Hi. I have a question about the results. Hopefully one of these things will pick it up. We have results based on how many new tests that we can do. We can actually measure how many tests get going without sort of threatening anyone's privacy. Do we know anything about the new rate of transmission? Have we had a real world effect beyond just more testing?
Yes, we should have had a graph on that. That's a great question. We have, and we can get that to the group or maybe put it on the website. But if you look at the Stop HIV/AIDS qualitative report, which is already up on the BC Centre for Excellence's website, you'll see that we have had definitely a marked decrease in transmissions beyond the trend. We already in BC were on a downward trend, but we've certainly had a more sort of dramatic impact. But at the same time, as we're expanding testing, we're finding people that didn't previously know their status. So we've changed the kind of the curve of the epidemic already quite a lot. And now we've got a bit of noise in there of people that we've diagnosed as a result of this initiative who have been HIV positive for quite a long time. I think it's still a bit early to see the real impact of treatment as prevention in the community fully, and we're kind of moving towards seeing in Vancouver anyway the need for a really combination prevention strategy where we still invest in primary prevention and things like that. So we really put a lot of effort into treatment as prevention, and we got dedicated resources to that. But we also now want to focus on how does that fit into a comprehensive strategy that includes, expanded access to condoms and needle and syringe exchange and these other more primary upstream, as well as sort of approaches that address it at a more determinants level.
Is there a way to attribute that marked decrease to this campaign, or do we have to work on assumptions?
I think that would probably be a bit generous because it's been part of all the work that Dr. Montana's been doing around quality of care and many different parts of the strategy. I think the only way to really do that is to do I don't know if you've ever seen the Do Bugs, Do Drugs randomized control trial where you did, one community had this marketing campaign and the other didn't. We haven't done that here. So I would probably say that'd be a bit generous, but I think that everything combined has made the difference.
So looking at the numbers of sort of the results of what's happened so far, it looks like the testing that's happened, the acceptance, the public acceptance of offered testing, seems really high, which might suggest that, the messaging is getting through. Whether or not that was asked specifically of those people, I don't know. But so would you say sort of your team that moving forward, if your goal is to move further towards universal testing and universal acceptance of testing, is targeting physicians going to have to be where you focus more to bring up the gap of who's actually getting offered the test? Would that be accurate?
For acute care, yes, that's going to be the majority of our strategy moving forward, is continuing to work with physicians to incorporate this into the practice. I think we underestimated the magnitude of this practice change. The reality of the situation is that clinicians don't get a lot of training in medical school, and once they do get, or when they did get that training, they were told that an HIV test required a 15 to 20 minute discussion, and so they had never practiced incorporating that into their practice. And now we're here telling them that this is something you should do, and this is how you do it. So yes, we still need quite a bit of work in terms of incorporating this into physician practice. But I also think that there are other ways that we can use by getting other providers within the acute care system to also increase that uptake.
I think Devin's.
Sorry. So now that I guess the STOP project funding is winding down, and the strategy is to have ongoing provincial funding and expand the initiative, what's next for the campaign? Are you going to be expanding that as well?
I think, so for those of you who maybe don't know it as well as Devin, the pilot is over and it's now rolled into an ongoing program, which is really exciting and I think unusual in healthcare these days. So we have some sustainable funding thanks to the Ministry of Health, and previously it was only in Vancouver and in Prince George, so in Northern Health, and now it's expanded to each health authority, so in Interior and Fraser Health and others. In terms of the campaign, we don't know yet. I think we're just in the beginning. It'll start April 1st that the other partners are coming online. So we're just in the kind of early days of, we had a big provincial knowledge exchange and the campaign was presented at that to the other health authority partners, and we'll be looking at, what's the next step. I don't know if you guys have an update, if you've engaged with any of the other health authorities, but definitely, we learned as a health authority the value of really investing in social marketing and investing in what was needed to sort of drive the change beyond just me talking with my PowerPoint. Didn't work.
We've spoken with a few other health authorities just in passing, presenting the case study and doing a little bit of a knowledge transfer around the actual campaign itself, but nothing official to the point that was mentioned. We are waiting on the next steps to really come through on April 1st and then deciding on next steps after that.
Hi, I was just wondering if you could speak a little bit about the parallels that you guys have drawn between those 4 social movements that you've talked about, and how my understanding of those anyways is that they were more kind of driven at the community level, and so just kind of thinking about social marketing and what that difference is or could look like. That would be really great.
Yeah, well, I guess I'll start and Vic carry on. But really the parallel we were trying to draw there was it's all of those movements worked because they were backed by not just the people they affected, but by everybody, and that everybody in community got behind them. And that was really kind of the parallel we drew with this, in that, the people we're talking to here are not the kind of the kind of obvious people you would think to talk to if you were trying to sort of to sort of solve HIV or kind of reduce it. So that's kind of where we came from, was talking to a kind of wider audience. And so when we say community, it's really the whole of Vancouver as opposed to specific communities within it.
And the power of taking that approach as well is that it's extremely disarming, because when you take that community-based approach, what ends up happening is all of the little side controversial, politically tenuous issues do fall to the wayside because they become more of that what discussion. You rally people around a common shared ideal, a common purpose, and through that, you can communicate to them in a more effective way. And when you eventually get down to that what discussion, they've already bought into what it is you're trying to tell them. And for that reason, they're that much more predisposition to joining the movement. So it really comes down to just how you structure the conversation itself, not going into the details, not going into the things that are going to be the emotional, political, whatever other word you want to use, landmines for them itself, but actually structure it in a way that's going to make them want to rally around it, believe in it, buy into it. We saw it happen in 2008 with the Obama campaign as well. It's a very, very similar kind of structure, and it's almost pattern-wise when they work and why they work itself.
I mean, it's, just to finish, just at its core, I think was, traditionally it was always, for a lot of people it was about how HIV affected other people and not them. And so really the job of this was to say, no, it's not actually true. Yeah. This is about you, not other people. It's about all of us and how we can all kind of make a bit of a difference. So it actually, in a way, appeals to people sort of selfishness as well and people's conceit that they think is that, they're immune to it and it's not something that's ever going to affect them. And kind of trying to break down those are probably the biggest barriers we're really trying to break down, in that, it's something that can affect every single person.
Further to that, question of using the web and using social media to kind of drive a broader awareness of things. How did, and obviously it's integrated with all the work that the nurses are doing day to day, right? And the lanyards that they happen to be wearing. And so what I'm interested to know is, what were the moments when you saw traffic being generated through your site, or you were getting a lot of feedback through the channels? Where did you see, what was it that drove that? Was it the bus posters? Was it a swell over time, or were there spikes, and how did you, what do you attribute those spikes to?
Sure. So it was a fairly standard swell over time that we saw. However, I think a lot of the groundwork that the team did in setting up the free media with the presentation that they did, as well as the Dr. Montener press conference, really helped on the launch of the actual campaign itself, really helped driving that spike. The key becomes is having the support structure from a communication standpoint around it. So once that big spike goes in, it can go viral. It's that whole analogy of starting a fire. You try to start a fire with what's it called? Lighter fluid. It's expensive, and it just, you're going to keep using it. So use that analogy for bought media. You're going to keep spending it. You're going to keep spending it. But if you try to start a fire with dry wood, your earned media, you just need a little bit of lighter fluid, that initial spike to get it going, and then that thing's going to keep burning. And in this case, that earned media is really that supporting communications infrastructure that allows people to take it and move it on. Because people talk about social media like it's something new. It's only been around since the advent of Facebook. The reality is that social media has been around since the first caveman saw a painting on a wall and then told his wife or his friend about it. All that's happened in the last 15 years is the technologies now exist that allow us to pass on information at a greater velocity than ever before. And so ideas can spread faster than ever before, as long as they've got the right infrastructure in place.
Right. So I meant to come back to that. The earned media was huge, right?
Yeah,
I mean,
absolutely.
People can talk all day about social media. That's just kind of like the infrastructure and communications channels. And if you get that earned media, that's just gravy, right? So I thought that was really interesting that you went out first, got some earned media, and then you had the support, right?
Exactly.
You had a really great website. You had the Facebook social media channel set up, so you're ready to respond.
Exactly.
Yeah.
And it's amazing, at the end of the day, it comes down to the message. So we talked about that why, how, what structure. If the message isn't compelling enough, you can be saying, if the message isn't compelling enough for individuals to connect to, it doesn't matter what you're saying. So you can have the greatest structure in place, but if the message isn't right, it's not going anywhere. So that was the other key component too, is just the message that was bang on and resonated with people at that why level.
Hi, great presentation. Love all the data, numbers are so fun. I'm just wondering, it seems to me like health professionals are kind of the gatekeepers in this campaign, and I love the golden circle theory, but I guess in order to have that take place, you kind of need all your things in order. How did you kind of tailor that theory to the physicians to get them on board and to kind of sustain the campaign? Because I really saw the spike once they got on board with that.
I think one of the greatest things I learned from this was that physicians and nurses are part of the general public too. And so it was really interesting to see the earned media have ramifications for the increased offer of testing. So I would go out to a group of clinicians sort of pounding the pavement to say, okay, can you please start doing this? Oh yeah, I saw that in the province yesterday. Or they were sort of queued up and primed because they had seen the press conference material through this, they're people too. And they saw the same bus shelter ads and so they were starting to parrot back. I mean, occasionally I went to some meetings, they would say, do you know HIV is different now? Actually, yeah. And they were, the same as actually at Les Faux Bourgeois, where I always go for my French food, and my bartender, you work in HIV? Did you know HIV is different now? And they didn't even realize it, but they were parroting back the sort of campaign. So that was critical. But we also spent a lot of time in the early days of probably a bit before Change HIVStory. It's different now, as more clinician facing, and we interviewed a lot of physicians and nurses, figured out what the stigma was that they still persisted with them, and settled on sort of 5 key messages of what we needed to change. And then we used like influencers like Dr. Julio Montana or Dr. Reka Gustafson, as well as Denise Becker, a woman living with HIV for over 20 years, to hammer home those messages at kind of clinician-facing level, as well as just, the silly things like lanyards that supported their practice change. And with them, they're amenable to the same, emotional story plus data. Maybe there's a little bit more data than in this presentation, but the same case stories and the same emotional reactions were just as relevant. Yeah. I don't know if you guys wanted to comment.
I think the only other thing to add to that was just that idea of pleasant surprise as well. So one of the things that we found really successful was a pie plate campaign where we put pie plates in the staff rooms, which had obviously delicious pie on it, but were also branded with the "It's Different Now" logos. Where previously, and I think Meaghan can talk to this a lot better than I, they wouldn't even let you put posters up in the staff room because it's a marketing-free zone and whatnot. But this was a way to almost it's Inception, right? At the end of the day, it's like you drop that message in there and it passes itself around. So it was also that idea of surprising and delighting in unexpected areas.
Hi. So I've worked in grant and research development for a number of years, and I've found often that when speaking to especially older scientists about doing kind of social media type stuff or just a more interesting knowledge translation, the response that I get and that often comes up is just that good research will find its way. Like, you publish in Nature, so the public will find out about what you're doing. So I'm really curious about, with this campaign, how the idea for doing something innovative like this came about, and then how you went about getting buy-in to actually follow that approach.
I can talk about it because we commissioned it, but I think we were lucky in that our leadership and particularly Scott Harrison and Chris Buckner were really already committed to social marketing, and this isn't the only campaign we did. We also had a very much more targeted campaigns to the gay community, for instance, in partnership with him. And so I think Vancouver Coastal and Providence have a fairly long tradition of investing in some social marketing, and sometimes you may not realize it, and it's our contracts, and we can be strategic about how we fund that, so it's like we don't get in trouble. But we sort of already probably had the buy-in from operational leadership, but it was a huge challenge to get, particularly physician scientist buy-in that this was needed, that you didn't just go out with your PowerPoint and say, this is the research. And I think it took trying that for almost a year and seeing, look, the data isn't changing. So the data drove the conclusion that it wasn't making an impact to just talk to people. And then drawing parallels with physician influencer campaigns or new practice updates that had actually worked. So Do Bugs Through Dogs is a classic example of people demonstrating, no, this is what you need to do to have an impact. Cervical cancer screening was another one that we drew parallels to and said, look, you have to have changes like a letter that each clinician gets every 6 months to say, hey, you haven't brought this patient in for a pap test, and the clinician feels accountable, much like our data did, as well as a lot of messaging to the public to say you need to routinely screen for cervical cancer, and to clinicians. So kind of drawing on the parallels of existing campaigns that had worked. I don't know. Add.
Well, it's also, I think, that with any kind of great research or any kind of great information, it's trying to make it as relevant to as many people as possible, because as great as it may be, if it's only focused on a very small number of people, or it's only ever really revealed to a very small number of people, the chances of it blowing wide open and everybody picking up on it are very slim. So I think a lot of it is just strategically figuring out how to position it, or which part of it to position, to kind of get people's attention and get people on board, which is really the kind of, I think, the key to us. And for us, it was a very humbling thing to work on, because we don't get to work on things like this very often. And so the chance to work on something that's so important and so potentially far-reaching that you've got the freedom to position to everybody was quite something. And yeah, you're right, it doesn't happen very often. And so you're very lucky when you get the chance to do that.
I was struck with the imagery that you're using in the campaign. It's really images of people together, and yet the HIV testing thing seems so private and in your doctor's office, and kind of the opposite from that. And I was wondering whether you gave any thought to trying to make it more public, like, I don't know what, like a button like I got tested, did you, or something like that, or just a way to kind of create more of a community around it?
We haven't gone down that road yet. Maybe we will, but for the time being, it was more about getting people to just consider the idea of getting tested and to go in. Maybe that's somewhere we end up going in the future, but for now it was more about explaining just the reality of the work that's being done and the effect that could have, and then using those images really to juxtapose, yes, the very private kind of nature of being tested, but the fact that we all do it and there's no stigma about it, it's nothing to be ashamed of. We can all kind of make a big difference. So yeah, maybe we'll go there one day, but right now it's more about just getting people just to accept the idea of getting tested in the first place.
I think that's it.
As communicators, we're always talking about consistency and repetition and trying to get the message out. And I was curious that you went from It's Different Now to Change HIVStory. Can you just talk about why that happened?
Well, we've kept the URL because it's something that we can repurpose in various different ways. But I think for this, Change HIVStory was just a line that I guess kind of got bandied around in the kind of early thinking about it, and then when we tied it against the thinking that taking those social movements as a basis for this campaign, it just kind of stuck. It's hard to explain some of these sometimes. They just kind of happen that way and evolve, and everyone likes it, and it kind of seems to people kind of pick up on it, and we knew with that line that we had something that people would remember. But by pulling it back to IDN and It's Different Now, we still kind of have a basis and a grounding for everything else. So even if the next campaign has nothing to do with Change HIVStory, the It's Different Now message is always still underpinning everything we do. So whilst it does seem very different, it's actually all the ideas come from exactly the same place.
I think just speaking from being involved in the really early days, and Steve Park, who was our previous strategist, he talked to us a lot about, because we originally didn't have the word HIV in the initial campaign, which you might have noticed, and that was quite deliberate because in their work, their exploration and research, they found that if we talked about HIV, people would just turn away. They wouldn't think it applied to them. They wouldn't listen. And so it was quite deliberate that it's different now, and it was quite vague, and the idea maybe I'll click on this or explore more, and then we'd try and get the key messages across in very focused ways. And so the idea was to sort of break through and then follow up with, then we felt like we'd laid the foundation for almost a year of that, and then we could start using the word HIV actually more strategically. And that was really hard for us public health people to wrap our brains around. We were like, but why doesn't it have go get an HIV test? Why don't you just write go get an HIVtest.org, or so that was really like Steve and Rob's kind of early learnings. And yeah, it was really cool I felt like I was in an episode of Mad Men every day at work. I was like, this is fun.
Awesome. Okay. Thank you very much. That was great. That was excellent. Really great to see the creative team here to explain that half and the total disconnect between day-to-day language and language that might be needed to actually drive awareness in the public, right? That's awesome. So thank you everybody for coming, and thank you for asking questions and being present and collaborating here tonight. I think I want to encourage you again to follow the eRounds hashtag and follow us on Twitter at Evening Rounds. We're on Facebook. eveningrounds.ca is our website. And so we can mingle here for a little while. I think we may adjourn to the Beyond Cafe if people are so inclined, which is right across the street. And we will be here again March 19th, right in this room, and we will announce the info as soon as we have it. Thank you again. See you next month.